Hello, everyone. Thank you very much for allowing me to give a little presentation on heart failure. This is something very important for all of us and all over the world. Congestive heart failure is an epidemic. Number one cause of expense for all the countries and for the community at large. If anything we can do to cut down the expense, I think it will be very much appreciated by all of us. Now, we are going to talk about conventional therapy and we are going to talk about acceptable therapy all over the world. Heart failure definition, which we all know, dysfunctional LV and RV. One ventricle fails to eject the blood, other ventricle gets filled up too heavily. Symptoms are very important for all of us to remember that this is a silent disease for a lot of people, but the reason is we do not give correct diagnosis, and the importance being patient symptoms are heart failure, or fatigue, shortness of breath, or tiredness. If the echocardiogram is not done, which is simplest test to do, we would not be able to predict survival rate. Now, as you can see the cost analysis and the prevalence, which we are going to talk, in USA, this is old data from 2004, but heart failure is one of the mega disease and prevalence is 5 million, which now I think according to 2012 estimated 6 million plus. Annual mortality is approximately 300,000 and annual incidence is approximately 600,000 for 2012. Also the cost-wise, it is amazing that old data shows approximately $40 billion were spent only on heart failure. 60% of the cost came for hospital part and 40% came from outpatient services. Just want to share the data with you what causes a heart failure. Number one cause is still coronary artery disease. 2/3 of the patient who manifest with heart failure, they have underlying CAD. Important part is why ICD in heart failure. The reason I want to share this slide is sudden cardiac death is most common way of finding the people whom we love perish quickly. And out of 100% people who were analyzed in 1997, 85% people were found to be dead secondary to ventricular arrhythmia and 15% were found to be dead secondary to bradyarrhythmia. So if we could have some solution for this both things at one time, I think we could save a lot of lives. The new way of thinking heart failure is staging the heart failure rather than class of heart failure. We have stage A, B, C and D. We all know about what each one means, but what if I may say, if we can prevent the patient from going from stage A to stage D, we will save a lot of lives. If we try to address stage A symptoms correctly before they happen symptoms, I think it will be a big benefit to the society. Now come to the real case study. 57-year-old male with history of MI 40 days ago, present to the emergency room with a shortness of breath, neck vein engorgement, has diabetes, left bundle branch, and ejection fraction is 30%. What should we do to this patient? We all agree the standard of care is ACE inhibitor or ARBs, beta blockers, aspirin, antiplatelet, statin, etc. We have included because we assume it is underlying cause is CAD. In CHF, we all need to get lifelong therapy, lifestyle modification, diet control, and frequent monitoring of symptoms for heart failure. Compliance still is a major issue. But in spite of that, patient has a symptom and ejection fraction is 30%. What should we consider? And the standard of care now all over the world, guideline-based medicine, is still addition of ICD, and we'll talk about that. Some people, because of financial stress or whatever, they may not choose to go for those options as a first line. Then what are the things available all over the world for people who meet certain criteria such as small vessel diffuse disease, with LV dysfunction is external counter pulsation, ECP, shock wave therapy, which is available. 2 of them are available in India. The new research is going on stem cell therapy, which is available, at least in Europe, for certain patients. It's not available for commercial use, but I think initial data is very promising, especially from group from the Spain. And obviously, people who may qualify for heart transplant, certainly we can have bridging technique for LVADs and later on cardiac transplant. Device therapy is a cornerstone for people with ejection fraction under 35% and certain time even above 35%. We will talk about what are ICD. ICDs consider very simply. There are 3 kinds of ICD: single chamber, dual chamber and bi-V. How many of you are aware of different ICDs in India? Raise your hands. And how easily is available in India? If I may ask, what is the cost factor? Is it the cost factor the major issue? From my perspective, our role as a cardiologist is to provide evidence-based guideline to the patient, and the choice will be there. Now, ICD also, we got enhancement, which we call CRT-P and CRT-D, which are available to some patient with left bundle branch block and with ejection fraction as per guideline. Now, why ICD? Because when we did analysis of modes of death, we find in class 2 and 3 heart failure, sudden death was more common than the class 4, where heart failure was more common as a cause of death. So I think initial studies which were done were very closely connected to arrhythmia. And this is what I want to show you. CRT, when you do it correctly, on the left-hand side, you can see there's a desynchronization, and you see on the right side, the symmetrical and resynchronization changes the ejection fraction favorably for patient. Another thing which I want to share is data on ICD in initial studies in 1990 and then in 2000. For those of you who have not seen the ICD, this is generator, single chamber and dual chamber. One lead is in RV, other one is in the right atrium. Classification wise and guideline based classification wise, there are lots of indication for ICD, especially for people who have suffered heart attack, like our case was patient had myocardial infarction 40 days prior to arrival to emergency room. His ejection fraction was 30%. He was on optimal medical therapy. He definitely meets class 1 guideline. Also, patients who have current symptoms of heart failure and reduced ejection fraction, has history of sudden cardiac arrest and unsustained ventricular tachycardia, they belong to class 1. Ejection fraction of 30 to 35% of any origin, whether ischemic cardiomyopathy or dilated cardiomyopathy, they would benefit in class 2 and 3. And anybody now with ejection of 30%, post-MI 40 days, class 1 even will qualify. Rare patient load is congenital heart disease with long QT syndrome and Brugada syndrome. They will all qualify. One of the early indications which we saw, people with prolonged ICD with preserved ejection fraction, they did little better when ICD was given versus those who were not given ICD. As the ejection fraction goes down, the survival rate goes down. This was one study which gave importance of prolonged QRS. Higher the QRS, higher the mortality. I want to show on the next slide, arrhythmia slide, which we show initially done in early 90s, AVID, CASH, CIDs, MADIT, and MUST trial. They were all done for comparison of antiarrhythmic versus ICD, and as you can see, all across there was positive benefit. Then all-cause mortality was studied in MADIT trial, MUST trial, MADIT-2, SCUD-HEFT, and Companion. All of them across the board, all-cause mortality was reduced. In summarization, anybody who has heart failure and ejection fraction 35%, ICD should be considered for sure. MADIT-2 was followed for longer time, up to 8 years we have seen the benefit. Absolute risk reduction was 31% at 3 years, and then When we follow up the data for 8 years, still you can see the divergence of the curve, benefit is maintained. So is it cost effective? Absolutely yes. Look at the p-value is 0.001. I'm very impressed with this data, and hopefully you all can take it, and for some of your patients who can afford to consider ICD is worthwhile looking at. SCRHAP data is also very promising, and it's also shown 23% reduction in mortality. CRT is standard of care for a lot of people who have LBB. Absolutely consider ejection fraction to 35%. CRT must be given as an option to the patient. Again, I would not go into detail. Initial trials were done in CRT-P, but when you add CRT-D, you get price of 2 for 1. You get tremendous benefit for bradyarrhythmia death as well as for arrhythmia death. So CRT has been shown all the benefit. How does it do? It take care of mechanical dysynchrony. Left and right ventricle, they were out of sync. It brings them back into sync. Everybody who has heart failure, they don't need CRT. Only people who will really get benefit is QRS for more than 120. Would every patient with CRT benefit? Answer is no. I just want to touch small slide on all the data which were done on CRT. All across you can see the benefit on Miracle, Contact DIM, Miracle ICD, Companion, CareHap, and Rhythm ICD. Everywhere we see benefit. Total patients studied were almost 4,000. In conclusion, CRTD reduces mortality, reduces heart failure hospitalization, and improves cardiac function. In a nutshell, it benefits society economically, improves the quality of life for the patient, and reduces the sudden cardiac death incidence. So I'm glad to say we all should consider in appropriate patient with heart failure, ICD as an option should be given to every patient. Affordability is a decision which patients should make, but our role should be guideline-based medicine, where as a standard of care, along with optimal medical therapy care, we should consider ICD on every individual whose ejection fraction is under 35%. Dilated cardiomyopathy, we should wait for certain days, repeat the echocardiogram, and then if they qualify, they should be considered. Thank you very much.
Thank you very much. The session is open for questions. I have a question now. If you have a patient with right bundle branch block QRS more than 120 milliseconds, and what would be the indication of doing a BiV or a combo device?
Now, question is, would he qualify for ICD or CRT? And what does he have associated ejection fraction?
Ejection fraction of 20% maybe?
I would not consider CRT. The guideline does not say it prolong the life, but ICD should be considered irrespective of whether they have right bundle or atrial fibrillation.
And what about patients if they cannot afford choosing between a single chamber ICD and a dual chamber ICD? How would you choose a patient for a single chamber versus a dual chamber ICD if there is no bradyarrhythmia or no AV conduction defect?
It's a very interesting question. And what do you do? Atrial fibrillation, if it's chronic for many years and the patient age group is, say, 85 to 90-year-old, which we still do in USA, those patients, you want to consider lifespan along with other factors. What are the likelihood that patient is going to go back into sinus rhythm? There, an individual clinical decision and each individual patient decision would be considered. If we can cardiovert them, then having the dual chamber would be worth considering. Younger patient, one should always be optimistic. We might get them back into sinus rhythm, because once patient is sinus rhythm, symptomatology improves significantly. And ICD has that potential to help certain patients. And there are no studies to say what percent of patient with atrial fibrillation will be converting to sinus rhythm.
What is the role of echocardiogram in guiding the placement of the biventricular pacing?
I think this is an interesting question, and I would dare to say in every hospital there are not enough right qualified echocardiographer who can help you to place the left ventricle lead appropriately in the coronary sinus or right position. So it's individual specific. To universities we have better record, but community hospitals, since our echo technician does it, I don't think success rate is that good. So you still need to do the guided radiological procedures to put it through the wire guided therapy.
As far as the indications for biventricular pacing, do you think that we should confirm that if the patient has got LBB, then he should have an echocardiogram to show that there is actually a mechanical dyssynchrony?
Yes, and that's very interesting. One thing I would go slightly different in that. The first is patient left bundle, he should get BIV, he should have correct position. But then when you are trying to do the CRT manipulation, that's where your echo technique, how you adjust all the AV delays and different parameters is going to be very, very important to see who are going to be responder and who are not going to be responder. But post-procedure echocardiography is very important tool to see whether we are going to see the benefit of BIV ICD or not. And that is something what with the now new technologies and new software which are embedded by certain companies such as Medtronic and St. Jude, is computer-based algorithm therapy which works better than echocardiography. It has become a little more easier. Another thing which I want to add, the new software which come with the ICDs and CRT is so easy, we can predict when the patient is going to heart failure. Now with the advent of smartphone, most of our patients we can monitor remotely from home. Thank you. Thank you very much.
Thank you very much. With this, because of the paucity of time, we are going to close this session and we move on to the next session.
Thank you very much, gentlemen, for sharing the proceedings of this session. Ladies and gentlemen, next is going to be a combined session.